Michelle.
Thank you so much, Lori. And I am so pleased to be here to represent Options for Sexual Health, and as always, to partner with you and your team and the folks at the WHRI. As you mentioned, a lot of us are highly aware of what's happening in terms of rights and reproductive justice. And in fact, I will lead off with Options is going to work with a number of organizations across the province and hopefully nationally to host an event here in Vancouver, October 2nd, a rally around reproductive justice and rights at the Vancouver Art Gallery with a small march to the US Consulate to let them know that their rights are important, but also to recognize that here in Canada, as folks are well aware, access to contraception and to abortion are not a fait accompli in every community. So I just wanted to do a little bit to talk about what COVID over the last year has meant for Options for Sexual Health. And in this digital world, when we think about World Sexual Health Day and the how sexual health exists within a digital world, what some of the opportunities and challenges have been for us. So I'm just going to share my screen. And there we go. Can everybody see that? Awesome. So really excited to be here on World Sexual Health Day. I have no conflicts every time I put a presentation together. And like Lori was saying, at Options, we're really aware that truth only comes, or reconciliation only comes when we're managing and navigating truth. So we want to acknowledge that our provincial offices are within the ancestral, traditional, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people, but our services are across many First Nations and Métis Charter communities across British Columbia. So we want to recognize that these keepers of the land and the sea and the sky who've been here for many, many years, that we're honored to be here, grateful to live, work, and learn. Just want to talk a little bit about Options, some advances and challenges during COVID, and then internet good and bad. So at a glance, our mission is to champion and celebrate sexual health. It's pretty easy. And then hopefully to be trusted and innovative leaders in a world that honors sexuality and diversity. So we do that through our clinical work. We have over 60 clinics in more than 55 communities. We do sex ed in schools and work with teachers and communities, as well as have an information and referral line, Sex Sense. And we're doing knowledge exchange and translation around women's HIV and HCV programming and knowledge. And that includes trans and cis women. It's important that women is a broader context. So in terms of advances during COVID, telehealth literally turned around on a dime within 2 weeks of things shutting down. We opened up telehealth and created an online booking system. So more access. As I mentioned, many of our clinics are rural and remote. So giving people an opportunity to book online meant that they had access to our services. We also, on the education side, mastered many platforms. As you can imagine, I'm sure you've been on Microsoft Teams, on Zoom, on GoToMeeting. So it's one thing to attend a meeting, it's another thing to master the ability to deliver programming. In terms of challenges, COVID protocols, I'm sure many of you who work in healthcare settings know that it felt like we saw more people, but we actually saw 36% less people because of the things that we had to do in between seeing people. In fact, we could only see one person at a time. And our clinics are really supported by amazing volunteers across the province, but those volunteers, we had to protect them and keep the risk minimal for them. So many of them couldn't show up at our clinics. And then so many of our nurses are already involved in public health. So recruitment and retention during this time was really challenging. And I think just keeping up morale was also a bit of a challenge. So I spent some time talking to our Director of Communications, Ashley Turner, and she let me know that in many ways the internet was a saving grace during COVID. So we increased followers across our social media platforms. And because we went online for so many things, people for the first time were able to attend events and be part of online meetings that we had never done before. And then accessibility generally for folks that have accessibility issues, those barriers were broken down. So that was amazing. The internet was spectacular. But it's not so good when you consider that our name, Options for Sexual Health, it's a problem. We have tried 3 times to actually have it be our URL for Facebook. It's not. Despite the fact that it's our charitable and registered name. So people are getting pretty creative across the internet. You need to search for sax, sex, socks, sex, and sex with a pound sign in there, which I actually kind of love, or sorry, the euro. So connecting through social media, unless you are was fine, unless you're BIPOC or providing sexual health education or really doing anything else that the Facebook gods deemed inappropriate. So for instance, during the 2020 election, anything that said had sexual content or sexual and reproductive health care was eliminated from the US election. Instagram was recently purchased by Facebook. And so content that's deemed by Facebook to be inappropriate is now being deemed inappropriate on Instagram as well. So you'll see as well that algorithms are wonderful. So you share, you like, you save. But the problem is that Options for Sexual Health, for instance, on our Instagram, people actually have to go to our page to see our posts because they get blocked. So access to reliable sexual health is already limited, but social media has great potential to be like the digital mecca. So right now, we need to normalize sexual health content and continue to advocate and ask people, where is the content? And that's it. Really excited to hear from everybody today. And as always, Lori and her team, thank you so much for sharing this day with us.
Thanks, Michelle. So with that, we will turn it over to Zeba and Bimbola, and maybe just a sneak peek that there will be a swag bag at the end. So please be sure to stay. Michelle, do you have it? Feminist and pro-choice AF. All right. Over to you, Zeba.
Thank you, Dr. Broder. That's wonderful. Thank you again, Dr. Broder and Michelle, for setting the tone for this event. I'm certainly super excited for the swag. And this actually creates a really great segue into our first theme. But before we get into that, I just want to quickly introduce myself. My name is Zeba, and I'm one of the research trainees at the Contraception and Abortion Research Team at UBC, and also a board member for Options for Sexual Health. I also want to quickly go over some community guidelines. This event is being recorded, so please feel free to keep your videos turned off if you don't want to be in the recording. Each of our presenters today will have about 4 minutes to talk about their research projects. During this time, please have your microphones on mute, and I encourage you to use the chat function to ask any questions that you may have. We have divided up the presentations into 4 separate themes, and before we wrap up each theme, there will be an opportunity to have your questions answered. So for our first theme, we will be hearing from Kiara O'Kane, Sonia Milani, and Khadija Mirzai. This theme explores the importance of paying attention in the digital world that we live in right now that is full of distractions. Akira, whenever you're ready, take it away.
Thank you so much. Hi, everyone. My name is Kiara, and today I'll be presenting Context Matters, but more so for women, the effects of gender and sexual activity cues on men and women's attention to sexual stimuli. Next slide, please. So there is a robust gender difference in the types of sexual cues that bring about sexual response in the laboratory. Cisgender gynophilic men, who are men attracted to women, exhibit a gender-specific pattern of sexual response, responding most to stimuli depicting female targets. Cisgender androphilic women, who are women attracted to men, display a gender non-specific pattern of sexual response, showing similar levels of response to stimuli depicting both male and female targets. One mechanism that may underlie this gender difference in arousal is differences in men's and women's attention to sexual cues. Previous eye tracking research has indeed found a gender difference in visual attention to sexual cues, where gynophilic men's attention is gender specific and the specificity of women's gaze depends on contextual cues within stimuli. However, the majority of these studies use static images to assess attention, rather than the dynamic video stimuli most often used in studies of sexual response. Therefore, in this study, we use dynamic video stimuli varying in gender and sexual activity cues to conduct a stronger test of attention as a mechanism underlying sexual response. Next slide, please. So based on the previous literature, we hypothesized that there would be a gender difference in the specificity of visual attention that would differ based on the intensity of the sexual activity cues depicted within stimuli. We predicted that men's attention would be gender specific regardless of sexual activity cues, while women's attention would vary depending on the intensity of the sexual activity cues. We tracked the visual attention of 33 cisgender gynophilic men and 36 cisgender androphilic women to a series of videos depicting male and female targets engaging in a range of sexual activities, including solo nude exercise, solo masturbation, and coupled sex. Next slide, please. When we compared attention to male and female targets, for nude exercise and solo masturbation, there was a significant three-way interaction between stimulus type, target sex, and participant gender. Men looked at female targets longer than male targets in both the nude exercise and masturbation videos, while women looked at male targets longer than female targets in the nude exercise videos, but looked at male and female targets similarly long in the masturbation videos. And for the same-sex dyads, there was a significant two-way interaction between dyad sex and participant gender. Men looked at female-female dyads significantly longer than male-male dyads, while women distributed their gaze evenly across female-female and male-male dyads. And finally, when we examined attention patterns to the mixed-sex dyad stimuli, we found a significant two-way interaction between target sex and participant gender. Like all other analyses, men looked at female targets significantly longer than male targets. Interestingly, women also looked at female targets significantly longer than the male targets, displaying a pattern of attention incongruent with their sexual attractions. Next slide, please. So, as hypothesized, we observed a gender difference in men's and women's controlled attention, which became more pronounced as stimulus intensity increased. Overall, the findings reveal that contextual cues impact women's attention to a greater degree than men's, suggesting that context is an important factor in women's sexual response. And finally, this data provides further support for the notion that gender differences in attention may be a key mechanism contributing to gendered sexual response. Thank you so much.
Okay. Hi, everyone. My name is Sonia Milani, and I will be presenting on links between attention to sexual cues during sex and sexual desire among pregnant couples. Next slide, please. So pregnancy is a vulnerable time, and compared to pre-pregnancy, new parent couples often experience declines in their sexual desire, and desire discrepancies among couples are common in therapy. Concerns with sexual desire often begin during pregnancy and can persist postpartum. Models of sexual response situate attention within sexual interactions as an important factor, and they predict that focusing attention on positive cues, so things like focusing on pleasure and physical sensations, facilitates sexual response and leads to increases in sexual desire, whereas attention to negative cues, so attention to bothersome thoughts or negative emotions, this can impede sexual response and leads to decreases in sexual desire. It follows that attentional biases may contribute to sexual desire difficulties, and during this vulnerable period, such difficulties can be risk factors for adverse outcomes, including postpartum depression, relationship dissolution, less sensitive parenting. And so to protect against these concerns, we wanted to examine whether there is a potential modifiable factor that could influence sexual desire. So the purpose of this study was to examine the association between individuals' attention to positive and negative sexual cues and their own and their partner's levels of sexual desire. Next slide, please. We had 129 pregnant individuals and their partners who were at 20 to 24 weeks pregnant with their first child. Couples independently completed an online survey containing the sexual desire inventory, which assesses the frequency and strength of solitary, dyadic, and other focused sexual desire. Solitary refers to an interest in engaging in sexual behavior by oneself, so like solo masturbation. Dyadic refers to an interest in engaging in sexual behavior with one's partner. And other focused refers to an interest in engaging in sexual behavior with an individual who's not your partner. As well, the attentional focus during sex scale was administered, which measures participants' attention to their own and their partner's positive and negative cues during sex. Next slide, please. In terms of attention to positive cues during sex, when pregnant individuals reported paying greater attention to positive sexual cues, both they and their partner reported higher dyadic sexual desire. When the partner reported paying greater attention to positive sexual cues, they reported higher dyadic desire. However, the partner's greater attention to positive cues were also associated with their own and their pregnant individuals' lower solitary sexual desire. In terms of attention to negative cues during sex, when pregnant individuals reported paying greater attention to negative sexual cues, they reported lower dyadic sexual desire. And when the partner reported paying greater attention to negative sexual cues, they reported greater other focused desire. Next slide, please. The key takeaway is that focusing attention on positive cues is associated with an individual's higher levels of desire to engage in sexual activity with one's partner. And this was the case regardless of whether it was the pregnant individual or their partner's attention to positive cues. Our results provide preliminary support for promoting attention to positive sexual cues as a possible way to cultivate sexual desire during pregnancy and beyond. And this study enhances our understanding of potential modifiable factors, such as attention to sexual cues, which may help inform new attention-based intervention programs to help couples better navigate changes to their sexual desire during pregnancy and postpartum. Thank you.
Khadija, if you're ready, you can get started. Khadija, are you present? I think we can give it a couple more seconds and then probably move on, if that's okay. Okay, well, we can jump right into the Q&A. Khadija. Oh, is anyone speaking? Oh, all right. We can jump right into the Q&A.
Hello, everybody. I apologize for the distance. My name is Khadija Mirzai. I come from Iran. My presentation is about the effect of counseling on pregnant women based on implicit model on sexual life quality and sexual satisfaction of couple during pregnancy. As you know, pregnancy is a critical period in women, which lead to change in her physical, mental, and behavioral aspect and cause a great change in her feelings, sexual desire, satisfaction, as well as number of sexual discourse. During pregnancy and even months after childbirth, sexual tendency reduce and sexual dysfunction rate increase than before a pregnancy. Thus, this could cause significant instability in the relationship between the spouses. So the aim of this study was to determine the effect of counseling on pregnant women based on implicit model on sexual life, quality, and sexual satisfaction during pregnancy. Next, please. This study conducted in 2 group clinical trial. 128 pregnant women whose pregnancy date from 13 to 33 weeks with the sexual problem were referred to the student and worker health center of midwife department in Mashhad to receive health service. All of women had entering criteria for the study. Those selected and randomly detected to the experimental study, which was 64 couple and control group 64 couple. Next, please. Our intervention was according to the Felicit model, which is very popular in the counseling for the health provider and midwife. And this model is one of the most commonly used and effective models used for the assessment and intervention for sexual problem. The first level is the permission. It means we must give permission for the people, for the women to talk about their problem, sexual problem. In this case, it was about the during pregnancy. The pregnant woman talked about their problem during pregnancy and what was the problem. And because we give permission, I think it's a very good opportunity for the women to talk about their concept, their belief, and their attitude. So this model, I think, is a very cultural sensitive approach. As we know, sexual health is a global health issue. For our intervention and for improving sexual health, we should and we must have a cultural sensitive program and intervention. So the first step give the mothers opportunity to talk about their problem, not what we want to expect from them. And the next level is limited information. It means we give limited information regarding their problem with the women and what is the problem. And as you know, many women, very young women, maybe they are not familiar with the changes during their sexual health during the pregnancy. So we must give their information about the physical and even psychological change during the pregnancy. After that is the third stage is about a specific suggestion. We give them according this model, a specific suggestion for them for regarding their problem, which might be, for example, sexual position. And it depends on what is the problem. And the fourth level is the intensive therapy, which is mean when we haven't get the result or intervention or treatment for the women, we can refer them for a specialist such as a psychologist or etc. Thank you. Next, please. So the result of the study was very good. The comparison of the mean score of couple sexual quality in 2 groups with different tests showed that there were no statistically significant difference between 2 groups in terms of the mean before group training. I mean, in the first of the study. The result of this test 2 and 2 for after the intervention, so the sexual quality score in the intervention group were significantly higher than the control group. And at week 2 and 4 after the intervention, mean score on sexual satisfaction in the interventional group compared to the control group was statistically higher, and this differences was significant in terms of statistics. Conclusion: sexual counseling of pregnant women based on Felicit model improves sexual satisfaction, and sexual life quality of couple during pregnancy. Thank you so much for giving me time, and hopefully my presentation was useful. Thank you so much.
Thank you, Kieri, Sonia, and
Thank you.
Khadija, for your
so
wonderful
much.
presentations.
Thank you.
We are slightly behind on schedule, so we're going to jump right into the next theme, but please feel free to use the chat function to ask any questions and continue the conversation with our presenters. So with our next set of presenters, we will be exploring how technology can enable access to sexual health. We have Natalie Brown, Kieran Palmer, Bryn Lavery, and Anthony Yuen, who will discuss how their research projects looked at digital innovations in health, in sexual health. So Natalie Brown, whenever you're ready, take it away.
Great, thank you. Hi, everybody. My name is Natalie, and I'm from UBC Sexual Health Research. And today I'll be presenting virtual reality erotica, arousing or anxiety provoking. Slide, please. So virtual reality, referred to as VR, is a technology that uses computer graphics and sensory inputs to create immersive virtual environments. Why is this exciting? Well, VR allows researchers to study how people respond to situations that are not easily simulated within the lab, like sexual encounters. However, very few studies have investigated women's responses to VR sexual encounters. So to fill this gap, one of our recent studies compared women's responses to 2D and VR erotic videos. And we found that one reported feeling more present in and aroused by the VR videos. However, considering that VR is quite an immersive experience and things may be happening in the scene that feel out of the viewer's control, we decided to examine women's anxiety in response to erotic videos and whether it was affected by stimulus modality, participant perspective, and past sexual experiences. So if you look at the bottom of the slide, there were two conditions for stimulus modality, 2D and VR videos, and two conditions for participant perspective. Video shown from third person when the participant viewed two actors engaging in sexual activity as an onlooker, and from first person when the participant was actually in the position of one of the actors in the sexual scene. And we compared the anxiety levels of participants who reported experiences of non-consensual sex to those who did not. How those experiences. Slide. So moving on to methods, participants included 37 cisgender women, and for procedures, they completed a survey at home, and then they came into the lab, put on a VR headset, and viewed erotic and non-erotic nature videos in a private room. For the erotic videos, they were able to choose whether they wanted to view a man and a woman engaging in sexual activity or two women. And they viewed 4 erotic videos that were 5 minutes in length, separated by 2-minute nature videos, and video order was counterbalanced across participants. So women completed the 6-item state trait anxiety inventory, the STAI, before and after each erotic video. And we conducted a mixed model ANOVA to examine the effects of video modality, perspective, order, and history of non-consensual sex on participants' anxiety levels. Slide. For results, if you look at the graph on the y-axis, you have pre to post video changes in STAI scores. So a higher score indicates greater anxiety. And on the x-axis, you have video order, whether the participant viewed 2D or VR videos first. So there was a significant interaction between video modality and order, such that women experienced greater anxiety in response to VR compared to 2D erotic videos, but only for women who viewed the 2D videos first. And we did not observe any effects of perspective or history of non-consensual sex on women's anxiety levels. Slide. So to summarize our findings, women reported greater anxiety in response to VR relative to 2D erotic videos, but order mattered. So we only observed this effect of video modality when women viewed 2D videos before VR videos. And perspective and history of non-consensual sexual contact did not affect anxiety levels. But null findings should be interpreted with caution due to the low sample size. So these results have implications for researchers designing studies that use both 2D and VR erotic stimuli. If you don't want to elicit participants' anxiety, show them VR first. And we found no evidence that women who reported past negative sexual experiences had elevated anxiety in response to erotic videos. We're continuing this line of research with our upcoming study VIVID, which examines VR erotica as a clinical tool for the treatment of vaginismus, fear of vaginal penetration, and is supported by grants from BCHRI and UBC. Thank you.
Hello, everyone. My name is Kiran Parmar. I am a research assistant from the Endometriosis and Pelvic Pain Lab, and I'm here to discuss the need for new digital health resources to support the self-management of endometriosis and painful sex. Next slide, please. So endometriosis is a chronic condition that affects 1 in 10 women and an unmeasured number of gender diverse people. Dyspareunia, which is the medical term for painful sex, is a symptom experienced by over 50% of people with endometriosis. So our objective was to describe patient experiences of self-managing endometriosis and painful sex to inform the development of digital health resources. We conducted semi-structured interviews with patients recruited from the endometriosis and pelvic pain cohort. Subjects had to be someone with endometriosis with experiences of painful sex. And we inductively analyzed the interviews using thematic techniques guided by interpretive description. Next slide, please. So we interviewed 20 subjects that ranged in age from 18 to 44 years and were predominantly identified as white and heterosexual. So the data describes how self-management is affected by social norms, by community factors, and by relationship factors. The community setting includes the interactions with the healthcare system, and many patients described how their healthcare providers had a heightened focus on discussing fertility during their appointments. Because of this heightened focus, it led to the neglected discussion of painful sex. Some participants described how their pain was dismissed by healthcare providers when they were teenagers. There seemed to be this age-based assumption that young girls describing their pain are exaggerating because they don't understand what a normal period is like. Feeling dismissed by healthcare providers at a young age led to being hesitant to disclose experiences of painful sex. Those living outside of the Lower Mainland described how limited specialists and the long wait lists were barriers to self-managing painful sex. Now looking at relationship factors, subjects described how the societal expectation of frequent sex and high sexual desire led to the stigmatization of reduced sex. There also seemed to be this normalization of painful sex as a part of womanhood, that going too deep would be painful for anyone. These expectations resulted in a delayed understanding that painful sex is a real symptom of endometriosis. Subjects described how communication with partners and the discussion of sexual strategies to reduce pain was important. So based on past relationships, subjects felt lucky to have found a partner that understood feelings of reduced sexual desire. Some subjects felt discomfort in speaking to their partner about painful sex. Next slide, please. So we've identified 3 overarching social norms. There are the gendered ideas that shape healthcare interaction, there's the societal expectations of women in sexual relationships, and the normalization of painful sex. These norms affect individual self-management of painful sex. Subjects described feeling guilty when they couldn't meet the societal expectation of what a partner is supposed to do. Subjects describe blaming themselves for painful sex, that sex hurts because they weren't able to relax enough. In a healthcare setting, self-management involved having to consistently advocate for themselves to have their pain taken seriously. As a result of social isolation, subjects often went online to read testimonials to determine what others did to self-manage their pain. Next slide, please. So these results show that there is a need for digital health resources to support the self-management of endometriosis and painful sex. These new resources should be patient-centered, that validate experiences of painful sex, to reduce feelings of isolation, to support communication with healthcare providers and partners, to reduce feelings of isolation and strengthen mental health. Thank you for listening to this presentation, and thank you to the WHRI for organizing this event to share important sexual health information.
Okay, hi, my name is Bryn Lavery, and I'm going to be presenting on the Debunking Desire campaign, sexual science, social media, and strategy in the pursuit of knowledge dissemination. Next slide, please. So 1 in 3 women will experience low sexual desire at some point in their lives. Since experiencing low sexual desire can be accompanied by feelings of shame and loneliness, our team with Debunking Desire decided to create the knowledge translation with the same name, #DebunkingDesire, which was centered around debunking myths on low sexual desire. Led through the experiences of our patient partner, our team used social media to share evidence-based information on low desire with the goal of creating lasting dialogues with women, their partners, their healthcare providers, and the general public. And our campaign was made possible through the funding by the Michael Smith Foundation for Health Research Reach Award. Next slide, please. So our knowledge translation, or KT campaign, used focus groups with women who experienced low desire to inform our campaign. We used their feedback and the regular consultation of our team's patient partner to create a short YouTube video, a social media toolkit, a website to host all campaign information, and a 5-question true or false quiz that was hosted on our website. These materials were then disseminated throughout our 10-month social media campaign, where we also hosted various live events and shared other educational information to the UBC Sexual Health Research Twitter, Instagram, and Facebook accounts. We also partnered with several influencers throughout the campaign to help amplify this content. Next slide, please. From the campaign, we were able to generate over 300,000 social media impressions. So that's the number of times a piece of content was delivered to somebody's page while they were viewing it. We appeared on 11 podcasts where our episodes were downloaded over 154,000 times. We had 2,060 completions of our true or false quiz. We garnered over 3,500 views on our YouTube video. And we attracted people from 110 countries to our website. And then we were featured in 5 media pieces. So the contributions of our patient partner, who was from Romania, and our social media strategist, who was from Turkey, also greatly impacted the international reach that we were able to observe, specifically in our YouTube video and our website. Next slide, please. So from the campaign, we had several recommendations for others pursuing knowledge translation campaigns and some lessons learned that we'd like to impart. So first off, for recommendations, collaborating with patient partners allowed us to shape our content to be the most applicable to our target audience, and influencers were then able to take and amplify this content to a wider audience. Second, we also paid a nominal fee for social media ads to drive viewers to our YouTube video, which was able to increase views to our video by 200% in just under 1 month. And then lastly, podcasts can offer a mutually beneficial relationship to KT campaigns, as podcast hosts are always looking for interesting educational guests to interview, which in turn gives campaigns and researchers free space to advertise their work. And then for some lessons learned, number 1, paying for advertisements in traditional media forms like newspapers can be very costly and often require pretty large declarations that it is advertised content, and it can also be difficult to track success through certain metrics. Number 2, creating a sense of community in a campaign can help increase the campaign's longevity. This might be through creating a regular and reliable space to share information on low sexual desire, or whatever your campaign content is, that extends beyond the life of the campaign. And then lastly, for website pop-ups, like the one that we used to advertise our Debunking Desire YouTube video, don't always necessarily translate into driving views to YouTube videos. Some people will just bypass the pop-ups. Okay, and that's it. Thank you all so much for listening.
Good afternoon, everyone. My name is Anthony, and I'm a 5th-year Bachelor of Science student at UBC and also a research assistant with the UBC Swallow Lab. And together we'll be exploring the link between misconceptions about sex and sexual well-being. Next slide, please. So sex is an important part of our overall well-being. However, many people receive little information or even misinformation about sex. And past research has found that having inaccurate beliefs about sex being linked to sexual problems such as low sexual desire and pain during sex, which can contribute to low sexual and relationship well-being. We initially sought to create a knowledge translation initiative to debunk myths about sex, but we also wanted to target our knowledge sharing to those who could benefit most from it. So this led us to the creation of our current study with the following 3 research questions. First, who is most likely to endorse myths about sex? Next, what are the links between myth endorsement and sexual and relationship outcomes? And finally, how can we use these data to disseminate evidence-based knowledge about sex to those who may benefit most? Next slide. Our study consisted of an online survey where we first asked participants questions on their socio-demographic information, such as how old they were, their religiosity, their political affiliation, whether they lived in a rural or urban area, whether they had received formal sex education in school or had taken a university human sexuality class, and also the age of their first partnered sexual encounter. Next, they were asked to rate their agreement to a diverse list of 75 myths about sex, ranging from topics such as anatomy, desire, arousal, orgasm, to partnered sex. Examples such as masturbation is unhealthy or pain during sex is normal. And response options range from strongly disagree to strongly agree, with also a I don't know option. Measures of sexual and relationship well-being include the global measure of sexual satisfaction and also the couples satisfaction index. Between February and April, using this online platform, we were able to recruit just over 400 undergraduate students, with the majority being assigned female at birth and just under 20% assigned male at birth. Next slide. On to the results. So first, we wanted to know who is most likely to endorse myths. So we analyzed socio-demographic factors that might predict myth endorsement and found that reporting holding more conservative political views and initiating partnered sexual activity at a later age was significantly associated with greater myth endorsement. Next, we wanted to look at the associations between greater myth endorsement and sexual and relationship outcomes. And we found that greater myth endorsement was correlated with lower sexual satisfaction and relationship satisfaction as well. Next slide. While data collection for our study is still ongoing, we have already started using the preliminary data to inform our online knowledge translation initiative called Misconceptions. Each of our Instagram posts aim to debunk one of the 75 myths in our survey, and we concentrate on the myths that are most highly endorsed or the ones where people responded most with I don't know. Two of the examples you see on the slide here were 2 of the myths that were actually most endorsed in our study. We try our best. We aim to use an evidence-based approach to ensure we are sharing accurate information that also captures the nuances of these topics. And next steps for our project is to evaluate the effectiveness of misconceptions in a future study. Thank you.
Wonderful. Thank you so much. So I'll get the ball rolling. I have one question for both Bryn and Anthony. So I see that with both of your projects, there's a big social media knowledge translation component to it. What would you say the most challenging part was in terms of engaging with folks? And I was also thinking about what Michelle had said earlier about how whenever you have the word sex in there, even if it is for an educational purpose, Instagram tends to shadow ban you. Was that ever a challenge? And maybe you can also talk about any steps you took to go around it.
Yeah, I will say for advertising our content, we absolutely ran into challenges of censorship for Debunking Desire. I believe we advertised on Facebook to direct viewers to our ad, and we had to change certain words, like instead of using sex, we had to use intimacy. And things like that. So being creative about our word choice in order to actually have our ad, 1, be accepted by Facebook, and 2, be delivered to the most amount of audiences. You do kind of have to like navigate these censorship restrictions in kind of a creative way.
Great, thank you for that, Bryn.
For us, we haven't quite looked at the engagement of our posts yet, but I think one thing that we definitely wanted to, just like Bryn suggested, is working with influencers to help us get our content out there. And we definitely also have worries about people because sex for many people is still a taboo and private topic. So we're worried that these posts might not be shared on people's personal and public Instagram pages. So those are things that we're definitely looking at. And thanks so much to Bryn for all the suggestions, because I think we'll definitely be taking a few pointers from you on that.
Fantastic. Awesome. So I see that we have two other questions in the chat. So if these are directed towards you, please make sure to answer them. We are going to be moving on to the next theme, and I would actually like to invite my colleague Bimbola to introduce the next theme and the speakers.
Thank you so much, Ziba. I hope we're all enjoying the presentation so far. I'm Bimbola Olure. I'm a master's student in the Department of Obstetrics and Gynecology, and also a research trainee with the Contraception and Abortion team. So our next theme will be looking at how digital tools and non-digital tools work together to deliver cohesive medical abortion. We'll have Hilary Kersin and Ina Sussman. So I'll hand it over to Hilary now.
So hi, my name is Hilary. I'm one of the residents with the Obstetrics and Gynecology team here at UBC, and I've been working with Dr. Cam and Dr. Gill on mifepristone, which is the tool that is out there right now to help support people following a physical abortion, and now we're looking to extend it for medication abortion. Next slide.
Hilary, by any chance, do you have a headset? It's just a bit muffled.
Ooh, I do not. Is it better if I talk loud? Is that better?
If it doesn't inconvenience you too much, if not, we'll just turn the volume up on our ends.
Okay, I can be loud. I'm kind of a quiet person. The fact of the matter is, in Canada, about 30% of women experience abortion. But as we've been hearing about today, and as we have seen, unfortunately, in our neighbors down south, there's still a huge amount of stigma and barriers and layers between people and accessing care. Next slide. So mifepristone is a tool that exists right now online. We're hoping we can move it into an app as well, but it has information and connects people with services to support them after their surgical abortion. With the advent of mifepristone in the past few years, we're hoping to expand that access to that support service to cover medication abortion and the unique needs that come with that compared to surgical abortion. Next slide. So we are looking to explore the needs and the preferences of people undergoing the procedure. We are using kind of a dual approach with key informant interviews, looking in depth at people's experiences, their needs, their preferences, as well as looking at quantitatively, like getting an idea of the demographics and the resources that people use. And with these individuals that we're working with to help to design the new piece of mifepristone that will provide supportive resources for medication abortion. Next slide. So we recently expanded our study to include anyone in Canada who's seeking or has undergone medication abortion. And as I mentioned, we're using a bit of a mixed methods approach with a quantitative survey and a qualitative interview. Next slide. So the survey is looking specifically at demographic information, how people use technology, what services they use, what they think they would prefer in terms of resource providing, and their perceptions of privacy and security, like what they would feel comfortable accessing with their devices, and their experience overall accessing sexual and reproductive healthcare, which has of course been very strongly faced by COVID in this past year. Oh, I'm having some trouble hearing. I will be louder. Next slide. That was it. Do we have any more slides? There's a couple more I'm expecting, but it's okay if not. No? Okay. I'll just tell you about the rest of it then. So the other part of our study is looking to do semi-structured interviews with, yeah, the hearing is difficult. I'm sorry, I don't even know where the microphone is. Sorry guys, I'll just finish up then. So we're looking to do semi-structured interviews with people who have had medication abortions, to look at their resources, the gaps in care, and what they would like to have in terms of online resources. We're hoping to use this to build out the new tool to provide support to people in North America and beyond, in terms of taking care of themselves and what to expect with medication abortion. We are still in the recruitment phase of this project, so if any of you are happy to share our posts and stuff on Instagram, I think my handle is in the resources from the resource document from today. And that's great. I'm sorry about the sound issues, but I'm happy to take questions and have a look at mypostcare.ca for more information.
Hi everyone, my name is Anab Zusman. I'm a PhD student in the Reproductive and Developmental Sciences program here at UBC. And today I'm going to talk about pharmacists' experiences with dispensing mifepristone for medical abortion in community pharmacies. Next slide, please. Abortion is a safe medical procedure commonly performed in Canada, with over 85,000 abortions reported in 2018. Mifepristone, used in combination with misoprostol, is an medication that induces medical abortion during the first trimester, which became available on the Canadian market in 2017. The introduction of mifepristone into Canada was intended to increase and simplify patients' access to abortion services and provide them with a medical alternative to first trimester surgical abortion. Initially dispensed only by physicians in the clinic, in November 2017, Health Canada indicated that once prescribed, mifepristone can be dispensed directly to patients by pharmacists, in addition to being dispensed in clinics, thereby increasing locations in which the medication can be dispensed. Next slide, please. Thank you. Our study aimed to assess pharmacists' experiences with mifepristone dispensing and accessibility in community pharmacies across Canada, utilization of medical abortion services, as well as assessing the familiarity of members of the community, such as physicians and patients, with mifepristone dispensing in the first 24 months since it was introduced to the market. Next slide, please. We surveyed 433 Canadian community pharmacists from across Canada, with completed mifepristone post-training baseline survey between 6.7 and 30.5 months previously. We summarized categorical data using counts and proportions and used chi-square tests to determine the relationships between categorical variables. Next slide, please. Overall, we had 125 responses. Of the 125 responding pharmacists, 56% had received at least one prescription for mifepristone in their pharmacy. No prescriptions were received through telemedicine. The mean number of prescriptions dispensed by our participants in the previous 12 months was 25.6, with a standard deviation of 85.7. 1/3 of participants used the mifepristone pharmacist dispensing checklist and resource guide. 86% of them found them useful. Approximately half of participants reported that their pharmacy stocks mifepristone. 80% reported that family physicians in their communities are aware that their pharmacies are stocking mifepristone, and 98.8% of our participants reported their communities reacted positively, yay, to the provision of mifepristone in their community. No differences were seen between urban and rural communities regarding these factors, and 81.8% of participants reported that their patients had to travel less than 30 kilometers to fill their mifepristone prescription. Reported benefits of dispensing mifepristone in pharmacies were increased availability and accessibility for women and couples with 94.4%, reduced pressure on the healthcare system with 85.6%, increased accessibility in rural and remote communities with 84.8%, and increased interprofessional collaboration with 39.2%. Challenges for maintaining an adequate stock at the pharmacy included low demand with 20%, short expiry date with 16%, and the cost of the actual purchasing of the medication with 7.2%. Next slide, please. We concluded that pharmacists are enthusiastic about providing patients in their community with convenient access to mifepristone. They believe that dispensing mifepristone in community pharmacies increases accessibility for medical abortion services in both urban and rural areas, while enhancing patient safety and reducing pressure on the healthcare system. An increase in mifepristone accessibility has the potential to enhance interprofessional collaboration by facilitating complementary physician-pharmacist counseling. Thank you very much for listening.
Thank you, Hilary and Ina, for the wonderful presentations. If you have any questions for them, please feel free to leave it in the chat box. I have a question for Hilary, but I'll leave it in the chat box. Ina, I was wondering, will there be a follow-up study for this? I'm curious to see like if the uptake of prescribing mifepristone is going to go up, since like there is like an easier access to it.
I sure hope so. I sure that this service will be taken more and more, because the entire idea of having mifepristone in the community is to increase accessibility. So the more pharmacists will be dispensing it, the more will be access to everyone who needs it. So this data is from a couple of years ago. So I sure hope that the numbers has gone up since then. Yeah.
Thank you. So we are going over now to our final theme, which has studies on COVID-19, HIV and AIDS, and genitopelvic dyspareunia. Will be taken by Nisha Marshall, Faith Jabs, Leah Tidy, and Peggy Frank. So I'll now hand over to Nisha. Nisha, you can go when you're ready.
Good afternoon, everybody. My name is Nisha. I work with the endometriosis and pelvic pain lab at UBC, and then today I'll be presenting on my master's thesis project, which is centered around creating a patient-reported outcome measure for genitopelvic dyspareunia. Next slide, please. So to give a little bit of a background of what genitopelvic dyspareunia is, it's a medical term for painful sex, and it affects between 8 and 22% of women worldwide. And today I'm going to be talking about two different types of dyspareunia. So the first type is called superficial dyspareunia, which refers to pain that's localized at the vaginal opening upon engaging in sexual activity, which is depicted here in the left image. And then in contrast, there is deep dyspareunia as well, which refers to pain that's localized deeper inside the vagina, again, upon engaging in sexual activity. So these two different types of dyspareunia are separate, but they can be really different. They can be really difficult to differentiate from a patient perspective. However, from a clinician's perspective, it's really important to be able to differentiate between these pain types because it can offer some insight into the etiology of the pain. So to kind of provide a solution to this issue, our research team has decided to create a patient-reported outcome measure, or a PROM, that helps to differentiate between these two pain sites and differentiate the impact that these two pain sites has on someone's life. So a PROM refers to a direct patient report that characterizes how a patient feels and functions in relation to a health issue that they encompass. Next slide, please. So the design of our project is based on the PROMIS framework, or PROMIS guidelines, that are guidelines for PROM researchers to use when they're developing their tools. And then a conceptual framework that we created with patient partners that outlines the important aspects of the dyspareunia experience. So things like intensity of pain, quality, timing, and then how the pain affects someone's behaviors, cognitions, affects, and sexuality. So we created these items for the PROM in reference to relevant questionnaires. So we looked at things like the McGill Pain Questionnaire, the FSFI, the GAD-7, and we took the framework for those other questionnaires and adapted them to our topic of interest. And then once we had a comprehensive item list for, that had potential for going on to the PROM, we gathered a panel of 4 patient partners and 3 clinicians to review all of these items. So this panel was sent a series of 2 survey iterations with all of the items that had potential for the PROM, and they were able to vote for inclusion, modification, or exclusion of items. Next slide, please. In terms of our results, we presented 164 items to our panelists. They underwent 2 survey iterations. And again, they were able to vote for inclusion, modification, or exclusion of these items and provide their comments on how they would like to modify or exclude items. And then any items that received over 80% inclusion votes were put onto the final prom, and then anything that needed modifying was put onto subsequent survey iterations. We ended up with a total of 176 items that reached consensus, in which 22 items were added, 41 were modified, and 10 were excluded. Next slide, please. In conclusion, the items that reached consensus display clarity, comprehensiveness, and clinical and experiential relevance with regards to the dyspareunia experience. And again, using that survey iterative process with our dyspareunia experts contributes to establishing content validity. And in the future, we'll be using qualitative and psychometric testing to further establish validity and reliability. Thank you everyone for listening to my presentation.
Hi everyone, I'm Faith Jabs, and today I'll be talking about the impact of romantic partner cohabitation and COVID-19 related stress on sexual desire, sexual behaviors, and sexual coercion in a Canadian sample. Next slide, please. So the World Health Organization declared a global pandemic on March 11th, 2020. And following this, there was quite a lot of media speculation about how the pandemic would impact our sex lives, with increased sexual activity and a baby boom being predicted. However, studies coming out of the US and out of China found that there was actually reduced sexual frequency, lower sexual desire, and declines in quality of people's sex lives during the pandemic. However, there was less research available on Canadian sexual well-being. And so the goals of this study were to examine the relationship between COVID-19 related stress and sexual health outcomes at the beginning of the pandemic, as well as evaluate the moderating impact of having a live-in romantic partner. Next slide, please. And so this is a longitudinal study. However, I will only be speaking to the first baseline set of data, which were collected in April and May of 2020. So participants completed an online questionnaire package, which asked about demographics, COVID-19 related stress, specifically around health, financial, and living situation concerns. They were also asked about dyadic sexual desire, frequency of dyadic sexual behaviors, and experiences of sexual coercion. And then we used hierarchical regression to analyze these data. And so our sample consisted of 1,019 participants across Canada, and the majority were female, identified as women, were heterosexual, were white, and the majority also had graduated from a post-secondary institution. The majority of our participants also had a romantic partner. And of those with a partner, just over a third were living with their romantic partner. Next slide, please. And so what we found was that higher levels of COVID-related stress significantly predicted higher levels of dyadic sexual desire. However, living with a romantic partner significantly predicted lower levels of dyadic sexual desire, yet also predicted higher levels of dyadic sexual behaviors. And what we found was that higher COVID-related stress for those living with their romantic partner significantly predicted a greater experiences of sexual coercion. Next slide, please. And so what I would like to point out in terms of what these data speak to is really this conversation about the shadow pandemic of intimate partner violence, and that our data show that the impact of stress on sexual coercion, particularly for those living with their romantic partner, and just sort of highlights what we've been hearing in the media throughout the year, which is that not everyone is safe at home. And our data also speak to future pandemic considerations, specifically around the potential for alleviating pandemic-related stress and how that might mitigate against negative sexual health outcomes. Thank you for your attention.
Thank you so much, everyone. I'm very honored that Peggy and I get to round off today's presentations. So hi, everyone. My name is Leah Tidy, and my pronouns are she and her, and I'm a postdoctoral fellow at the University of Victoria in the School of Public Health and Social Policy. Peggy, do you want to introduce yourself, and then I'll get going into it?
Sure. I'm Peggy Frank, living in Victoria, also an HIV activist for many years, a researcher and an artist in our community.
Thanks, Peg. So our work, the title that we're working with right now it was just something I hid away. I hid away. Older women's experiences of living with HIV and AIDS in British Columbia. Next slide. Sorry, you can stay on this slide for now. So what we're looking at is women's stories of living with HIV, and for too long, their stories have been really mired in social stigma and routinely silenced in popular culture and also in academia. This is particularly prevalent among older women who face a double bind of ageism and sexism that impacts their embodied experiences of sexuality. So in response, a collective of older women living with HIV and AIDS across British Columbia are sharing their stories through our community-led arts-based project that utilizes both online and in-person artistic creation and expression. Next slide, please. So this is just a very brief outline of our project. We're just in the shifting from gathering stories to creation. So this project draws from women's stories of living with HIV and AIDS and data from UVic's community-based health equity research group, a project called HIV in My Day. And this is an existing collaboration between academic researchers and community partners that has produced a digital archive of 117 oral history interviews with long-term survivors of HIV and their caregivers. And 25 of these interviews are women's stories, and that forms the basis of our story gathering. We're then bringing these stories together to host an artist retreat gathering for older women living with HIV in Victoria. And we're going to respond to these oral histories and also create art based on their own stories and their experience of hearing these stories played out for them. This will be co-led by Peggy and myself to explore various art forms as methods of self-expression, of knowledge sharing, and mobilization about the impact of the early days of HIV on women. And then based on this gathering and what we create together at that artist retreat, we're going to share an art installation collage here in Victoria that will engage audience members in the community to witness and then engage with the art that we've created. And lastly, through observation, audience surveys, and reflections with this women's collective, we're going to engage in a collective meaning-making process and create a shared knowledge dissemination plan to extend our work beyond that installation to folks across BC. I'm now going to pass it to Peggy while we move to the next slide.
Okay, thanks very much, Leah. And one of the things that is really persistent in this research is that it adheres to a theme of MIWA, which is nothing about HIV without the participation of the HIV community. And I live with HIV and have for many, many years. And so stigma is one of the things that I recognize as a unfortunate but prevalent and sticky, and it doesn't ever seem to go away, theme. And so that's one of the things that we're pulling out from all of the women's stories. Another is the lack of not education per se, but the lack of formal education or academic education and how that's affecting women's lives as they live with HIV. And the resilience, education also, I'm going to come back there and just say that there is also education around criminalization of non-disclosure of HIV status was a huge piece of what stopped women from having healthy sexual lives. But women are resilient, and that's coming out loud and clear in the stories that have been collected. There's also an element of shame associated with HIV, and that I think is one of those things that crosses through many things like abortion as well, and that blaming and shaming, which isn't realistic, but it's very, very common. lack of support, especially for women living in rural settings or isolated situations. For whatever reason, they can be in the center of the city and still be isolated. And so the last theme that we are pulling out is heartbreak, and that the title and the discussion about hiding really allows you to see how heartbreaking it is that people will limit their sexual life and their relationships based on living with a virus that can be totally controlled. And when it is totally controlled, is totally non-transmissible. So that's where we are. And I think we just have one more slide there. And this is one of the people who was interviewed says, I think to a certain extent, I think it's us who should do the educating. I think it's us. It's time for us to step up, like the old timers that have HIV to step up. And so that's really what we're trying to allow the women to do. And so we don't really know what the answers are. They'll be told by the women themselves. And the final slide is just a thank you, I think. Yeah.
Thank you very much for the wonderful presentation. We've come to the end of our presentation. If anyone has any question, please put it in the chat box. So I'll now hand over to Michelle to announce the winner of the goodie bag.
Well, I just want to say thank you so much to everybody. All of the presentations were amazing, and Zeba and Bimbola and I have been kind of chatting back and forth, and there were so many to choose from, and so we had to kind of think about the theme related to World Sexual Health Day, and we've actually landed on Kieran's presentation as a presentation that was both informative and clear. I love that Zeba, one of the things that was important for her is your timing was perfect. And as a researcher, I know that that's important to Zeba, that things are very well organized. So thank you to everybody. I sent a private message to Lori that this is honestly one of my favorite days of the year. It's so inspiring to see all of the research and all of the work and all of your presentations. So thank you to Kieran, but thank you to everyone. And thank you to Lori and her team again.
Thanks, Michelle, and congratulations, Kieran. So just a reminder, Kieran, what you've won, in addition to some fabulous swag, Feminist and Pro-Choice AF from Options for Sexual Health, we are throwing in a copy of Jen Gunter's, you can't see it, the Vagina Bible. This is my copy. You'll get a new copy, and reach out to us at the WHRI to arrange for pickup. Want to encourage all of you to do your part in sharing good, accurate information about sexual health. Again, there's so much misinformation, there's so much bias, and there's so many opportunities for you all as trainees to do your part to make this world sexually safer and healthier and more pleasurable. And some of the ways that you can do that are by following optionsforsexualhealth.org, WHRI.org. We're all over social media. WHRI also has a podcast at Women's Research. And in fact, would love to see if any of you would be interested in coming on our podcast to say a little bit more about the work that you do. So with that, thank you all. Huge, huge thanks to Bimbola and Zeba and Melissa Nelson from the WHRI who put today's event together behind the scenes. Truly amazing presentations. So proud of all of you. Keep doing your terrific work. And with that, we will sign off. Have a good weekend, everyone.